We are now going to discuss residual and persistent incontinence. Residual incontinence is perhaps the most worrisome situation for our fistula patients because after they've had their repair, they're so excited to finally have had their surgery that actually if they get another problem, it's quite heartbreaking. As we know, the bladder function is simple. It's a question of storage for 99% of the time and voiding under voluntary control 1% of the time. And we hope that when our fistula patients have had their surgery, they would be able to do exactly that. But we also know that normal bladder function depends on not just the integrity of the bladder, but the whole central nervous system and the peripheral nervous system. Many of our patients may be fine, but they'll present with symptoms of either leakage if they cough or sneeze, or they might have problems with frequency and urgency, or problems with infections and a sense of dysuria, problems with incomplete emptying, and now increasingly we're seeing prolapse and problems with sexual dysfunction. Now, if it all fell within a nice little box like this, it would make life quite easy. But generally, this is what happens, that most patients actually have a multitude of symptoms, and perhaps even more so in our fistula patients, trying to work out what is causing the problem is not always easy. In certain settings, you can take a urine sample to rule out if the infection is present, and in under-resourced settings, this is possible. In most under-resourced settings, you can now do free uroflowmetry and cystometry to look at bladder function. In most women, when they pass urine, this is what you hope to see, a beautiful bell-sized curve. And if you look at the rest of the ICS website, you'll see a huge amount of information on how voiding should occur and how it should take place and what's normal. Perhaps this is more commonly what we will see in some of our patients, where they have an intermittent pattern to their voiding and there's quite clearly some element of abdominal straining. One of the most important aspects after fistula is to rule out the possibility of a high post-void residual. One of the major issues is that many of our fistula patients may be able to store urine, but may not be able to pass it adequately. So in order to ensure that they have done so, you can either use an ultrasound scan to measure what's left in the bladder after the patient has voided or catheterize. And generally, we have a rough parameter between 50 mL to 200 mL as being within the normal range. However, it's important to put that in the clinical context. In a patient who has got a small bladder, a residual of 50 mL may be too high for her. Some people use a percentage, and therefore a third of the bladder or more suggests there is a problem with retention in this patient. This is the scan that you can use, and many hospitals now in the underdeveloped world or perhaps the under-resourced world do have a similar device to use. This is just a picture to show how you can assess the bladder quite easily. What about the role of urodynamics? Well, there's a huge amount of information on urodynamics on the ICS website, and it's increasingly becoming used in the settings where fistulas are repaired on a regular basis. This is just a simple slide to explain what happens, and we use subtracted cystometry. The two most important things for us to look at is what's in the bladder, in other words, the volume in the bladder, and whether the detrusor is working well or not. We expect when the patient voids that they generate a good voiding pressure and they're able to empty the bladder to completion, as shown in this trace. One of the commonest things we see in patients who have had fistula repairs is urgent incontinence, where they complain of severe urgency, frequency, and an inability to get to the toilet on time. There may be multiple triggers, but really it's that sort of sense of distraction and upset when they find themselves losing urine because they simply can't stop themselves. There are different types of traces you can look at, and this is just a typical trace showing overactivity of the bladder. The vast majority of our patients after fistula surgery tend to have a combination of both stress incontinence and urge incontinence. It's a very common presentation, and often you do need urodynamics to confirm the diagnosis. Chronic urinary retention, as I alluded to earlier, is perhaps more of a worry because it's not often picked up easily. So therefore, it's important to make the diagnosis and to make a decision. Is it due to the fact that the bladder muscle is not working so well, or is it due to the fact that there's an outlet obstruction? In other words, maybe the urethral procedure is too tight. So all of those aspects need to be taken into account, but also bear in mind other possible causes. There are other problems as well, and I've alluded already to the urinary tract infection issue, but often we have the problem also of restricted mobility in patients, particularly with flexure dysfunction and flexure injury, problems with constipation. A lot of these young women will be in the hospital for the first time in their lives, so they've come from a very different setting to different types of environments with different types of food. So constipation can be a driving force for some of their symptoms. Often they're on other medications which also impact on them. And of course, the big factor here is the psychological deficiency, which can be a problem in some of our patients. These are some papers to gradually explain what's been going on in this population. So this is from the Addis Ababa hospital, where they looked at 154 women in whom they did urodynamic assessments. And they found that roughly half had stress incontinence. The other half practically had mixed stress incontinence and overactivity. And the percentage of patients who had pure detritus overactivity was quite small. It's quite clear that after fistula surgery, we have a problem with the urethral complex, but I suspect it depends which population you're dealing with. The vast majority of patients who've had fistula surgery often will have had compromise and trauma to the urethral complex, particularly at the bladder neck, so it's not unexpected that stress incontinence is a major component. But this is why pelvic floor rehabilitation is critical. This is another study by another team from the Aga Khan Hospital looking at 157 women, and they basically got similar outcomes, slightly higher outcomes in relation to urinary stress incontinence and slightly higher with urgency. But on the whole, it does sort of give you an idea of what is out there in the post-fistula repair population. What was interesting in this study is that even though the urodynamics suggested this, it didn't fit in with the clinical findings. So therefore, there's no point in correlating the two without really assessing your patient on an individual basis. So we need to listen to our patient and work out what symptom is driving her problem. The therapies are many, and I'll just give you a few brief ones specifically for the fistula patients. So we really look much more towards pelvic floor rehabilitation and physiotherapy, and you'll hear my colleagues speak on this. Although we know the etiology is due to attenuation, it's often the whole support system may have gone. And although the continence procedures of old that have now become standard practice in our environment, such as the mid-urethral tape, it is probably not appropriate to use it in fistula patients as they have extensive scarring and pure vascularity of the tissues. Therefore, putting in any prosthetic material is likely to cause problems. There is a role for mid-urethral injections, but they do get absorbed, and you're dealing with patients who are hopefully going back to their community, and to come back to see you for top-up injections, it's really difficult. The same applies to bladder neck injectables, which are known to be efficacious as well, but they do need to be topped up every once in a while. In some situations, such as that of the Addis Ababa Fistula Hospital, when my colleague Steve Arrowsmith worked there, he used to use fat tissue to try and inject directly into this area, and it was very helpful. However, it does need to be repeated at regular intervals. Of course, there is also the corpus suspension, which people can use, but you need mobility of the tissue in order to achieve this. In the overactive bladder, there are many medications that are now available, and in the under-resourced settings, not everybody has access to them. Oxybutynin seems to be available, but only for a short period of time. And perhaps that's the next step. We need to integrate more with our pharmaceutical companies to make sure this is available for all of our patients in under-resourced settings. What about the role of botulinum toxin in treating the overactive bladder? Well, we now know it is very much recognized as a very valuable treatment for overactivity in patients who are not compliant to their medication or have had difficulty with their medication. And it has now become licensed, but we have to look at its role in that setting. It's still not been studied, although I do believe there have been some pilot studies suggesting it may be helpful. The other things we sort of base a lot of our work on really is looking at the role of catheterization in patients with high retention rates. And in some situations, we may even need to consider a permanent indwelling catheter. But perhaps the big area now is what do you do with the patient in whom the fistula repair was not successful? Or perhaps the fistula repair was successful, but they're having several problems with other types of incontinence. So you really need to look at urinary diversion. And this is where our colleagues in urology would be very helpful. There are multiple procedures that are available, and depending on the patient and what their needs are, will determine what type of operation can be offered. In the under-resourced settings, quite a few of my colleagues in fistula surgery perform the mains pouch, particularly ureterosigmoidostomy, because it helps patients have a way to keep themselves continent, even if the bladder has become pretty much a useless organ to them. It's not an easy operation, but it seems to work very well, particularly if the integrity of the anal sphincter is truly and totally intact. The other procedure we are seeing more of is perhaps an ileal conduit, and more patients are having stomas put in when they have a very intractable and difficult situation. But you have to bear in mind that many of the patients do not like the concept of a stoma. It's very difficult to manage in under-resourced settings because they often do not have the bags that they need, and so on. So this is not an easy decision to take and needs to be fully supported with the patient and discussed with her family, because this is a decision for life. So really, in conclusion, we know that there are different types of incontinence, and we have to look at whether urodynamic studies are helpful, particularly for patients who have persistent problems with incontinence. But don't forget that they might have had a recurrent fistula or a persistent fistula, or sometimes, very rarely, in a missed fistula. So you might have repaired the most big fistula, the one you could see, but there's another little one sitting somewhere else. You do need to use different assessment techniques, and they need to be affordable, and you need to be able to use them in an under-resourced setting on a regular basis. And therefore, for us to get better at this, we need to engage all fistula surgeons globally and their advocates to develop better assessment pathways and treatment pathways.